Hello, my name is Emilia Santiago. I am a PTA student with South College. Today's video is regarding information about the lower extremity amputations. So I'll be talking about the location, surgical procedure, the prosthetic impact, and common causes for an amputation. So I will be going from proximal to distal. So for hip, there is a hip disarticulation and a hip amputation, also known as a hemipelvictomy. Usually with the names of the amputation has to do with the location. So the hip disarticulation is involving just the hip joint, and then a hemipelvictomy or a hip amputation involves the hip joint and part of the pelvis or all of the pelvis. Then we go into the transfemoral amputation, which is between the hip and the knee, so it would be right here. Then we also have a knee disarticulation and a knee amputation. The difference between those is the knee disarticulation is involving the hip, the knee joint, where it still includes the difference between the knee disarticulation and a knee amputation is the femoral condyles. So it would be these little fellows right here. And for a knee disarticulation, those are still preserved. But for amputation, it is slightly above, they cut part of the femur, so therefore the condyles are no longer preserved. Then we have a transtibial amputation, which is right here. We also have a Symes amputation and an ankle disarticulation. The difference between those is the heel pad. So for a Symes, the heel pad is preserved for weight bearing, and for an ankle disarticulation, it's just at the joint. And then we have a transtarsal amputation, which would be right here. All right, now regarding the prosthetic impact by amputation level, for a hemipelvictomy and a hip disarticulation, like I mentioned before, the difference primarily is the pelvis, but both of them do prosthetic wise. It is extremely complex because often it is attached to the trunk, and energy demand is really high. So most patients often depend on their primary mobility, the wheelchair. For a knee amputation, for a transfemoral amputation, loss of the knee joint requires a knee prosthetic. So gait is less energy efficient and requires more training below the knee. Femoral or knee above knee amputation. The femur is basically the femur we cut above the knee, so the knee joint is at loss, which means the patient requires a prosthetic knee joint. Compared to below knee amputations, gait is less energy efficient and prosthetic training is more demanding. Patients generally need more practice to achieve safe functional walking, and activities like climbing stairs are more difficult. For knee amputations, which is above the condyles, like I mentioned, with the knee disarticulation, the knee condyles are still intact. Therefore, it's preserving a little more limb than standard above knee, because no condyles remain. So the weight bearing weight bearing is a little different. So therefore, a shorter femur leverage for control is controlling the prosthesis. So gait efficiency is lower than a knee disarticulation. But, it's still, ambulation wise and, training or not training, but practice for a patient might be somewhat better. As for a knee disarticulation, the femur condyles are still preserved. So, it does give the patient, the maximum limb length. I'm sorry for my wording or my slurring, which is, a good leverage for controlling the prosthesis. So for weight bearing, it's the femoral condyles makes the it has pros and cons, but like the condyles are still intact. It could make the socket fitting a little more challenging. Oh, excuse me. And the knee prosthetic is a little slightly lower than the sound side, but overall, like I mentioned, the difference between knee disarticulation and knee amputation is that those condyles. For a transtibial, which is below the knee, amputation removes part of the tibia and fibula, but preserves the knee joint. So this is one of the most functional levels for a prosthetic, because the knee allows for more natural and energy efficient gait. So patients with below knee amputations typically are able to walk with less effort than those with above knee amputation. So like practice wise, or just getting used to that amputation, it might be any kind of amputation. A lot of patients, it's hard concept to grasp, but with patients who have get the transtibial, it's slightly easier for them to gain that gait back into that going back into that walking, maybe running, and just normal, well, not normal, that's not a correct term in my opinion, just going back into that routine. That's what I meant to say. For ankle disarticulation, the ankle disarticulation, the Symes amputation, the only difference between those two is the heel pad. So for ankle disarticulation, it's at the joint, at the ankle joint, and the heel pad is not preserved. So because the heel pad is not preserved, usually the weight bearing, it can be a little difficult, or they can't really directly weight bear on the residual limb, and the prosthesis must carry most of the load through the socket. Usually the residual limb tends to be narrow, which can make the prosthetic suspension a little more difficult. As for Symes amputation, it is the heel pad is intact, so the weight bearing for a patient is directly on the residual limb, even without a prosthesis because of that heel pad. So it is a big advantage for short distances, and however, the residual limb can make the socket fitting and shoe wear a little difficult. And lastly, our transtarsal amputation is at the most distal level. So part of the forefoot is removed, but much of the natural weight-bearing surface is still preserved. So that would be like, the heel, it's just here in the middle of the forefoot. So usually these, the patients or individuals who get this kind of amputation often can walk short distances without a prosthesis. Obviously using special footwear or some shoe inserts instead. When a prosthesis is used, though, it is usually shorter or more cosmetic, but shoe fitting can still be a little challenging. So a common cause for amputation is vascular disease. A major contributor is diabetes mellitus. I'm sorry for the pronunciation. Usually with diabetes, as we know, can damage both. Whenever an individual has diabetes, can damage nerves and blood vessels, or neuropathy is common. So, which means reduction of sensation in the feet or in the foot, in the feet, which, if an individual is unable to feel whenever they get injured, that can go untreated, which later can cause infection. That infection can worsen, therefore can lead to an amputation. Another common cause could be peripheral arterial disease, or PAD. It occurs when narrowed or blocked arteries reduce blood flow to the lower extremities. Without good circulation, tissue doesn't get enough oxygen or nutrients, which can result in tissue death. So once tissue death sets in, amputation is necessary to prevent, infection from spreading. While, there's vascular disease is the leading cause, there are also multiple reasons for amputations, whether that be trauma, an example would be, trauma like a motor vehicle, or something like cancer, or just, there can be just multiple leading causes to get amputation. So I'll be demonstrating a common gait deviation, which is circumduction. So circumduction is when the prosthetic leg goes in an outward arc motion during the swing phase. So this could be a cause of the prosthetic being too long. So it makes it hard for the foot or for the individual to have a clear swing phase. So the patient compensates by going into that little, outward motion. So this could physically cause, weak hip flexors and or just reduce confidence in knee control. which can make the patient avoid bending the knee. So, they compensate by doing that outward motion. So this deviation, can increase, the individual using more energy, or, can cause asymmetry, which can lead to, overuse or, injury on the sound leg. For any patient that has been involved, for any individual who is going through the processing of an amputation, at the moment they might feel frustrated and, emotionally, they might be at their lowest, trying to process, this new lifestyle. So I would highly recommend, talking to a peer who has gone through this. Emotionally, there might be a way that they are able to understand you more than I, as a PTA or a provider, or the PT or doctor or nurse, might not be able to help emotionally. Also, they've been through that same boat, like pain-wise, processing. So it's always best to be able to talk to somebody that's going through the same, just the same, thought process, just going through this same, new lifestyle. They might be able to even, give certain, like, advice on certain things to do, or just like, transfers, like, there might be certain ways that they do it and it's easier on them, and they can, pass it on to you as a new, amputee. It's always better to have somebody who you can emotionally or just bond with overall, who is going through the same thing as you. Us as humans, we try to always, stick together to people that we know are either going through the same thing, or, that, because the first thought process whenever somebody tells you, oh, I know, I understand, but in reality, you inside, or deep inside, know that they will never understand what you're going through. So maybe somebody who is, has been through, and at the end of the day, it's kind of like trauma. They're able to, you're able to feel a deeper connection that you might not be able to share with your PTA or with your doctor. So it's highly recommended to, have a peer or peer mentor to help you with this new transition and this new life. My patient has a transtibial amputation. So therefore, positions that we're trying to avoid is having them in knee flexion and hip flexions, because this could lead to contractures. For correct positioning of a transtibial amputation, we want to have a pillow not directly under the knee joint, but slightly below it, to avoid either further, contractures or just injury. Also, you want to try to have the legs close together, not in an abducted, because you want to try to avoid developing that abduction contracture, or it could also end up as a gait deviation. let's put that back together. Alright, now for key stretches for transtibial or transfemoral amputation is hip flexors. I'll be demonstrating each stretch here in a second, but I just want to describe the importance of each one. So for hip flexors, we're trying to stretch our hip flexors because that is one of the most hip flexor contractions are among the most common contractures due to a lot of individuals with these amputations just sitting down. So usually, when you're sitting down, more often than not, you are in a flex or hip flex position. So we're trying to get this stretch so we avoid getting a contracture there. Another one that is another key stretch is your hamstrings. So we do this in a supine position, which I'll be demonstrating here in a second. But we are trying to avoid that knee flexion or getting that knee flexion contracture. So we stretch out our hamstrings to avoid developing that contracture. All right, I'll be demonstrating how to stretch your hip flexors. This would obviously be done in a more comfortable, so I'll be demonstrating a hip flexor stretch. Obviously, this would be done on a more comfortable surface, whether that be a mat, a floor mat, or a bed, therapy bed, or just a bed. This stretch is done in a prone position. So you would lie prone, which is on your stomach, and you would go up on your elbows. My hip flexors are right here. So that would be your psoas and your iliacus, and then you would go up on your elbows and just push, and you would feel that stretch. Now, another stretch that I mentioned was a hamstring stretch. Now, how you do this stretch, there's a few ways that you can do a hamstring stretch. One can be done with another individual helping either the patient, or you could also do it, pause. All right, so I'll be demonstrating a hamstring stretch now. So this can be done in two ways. One is supine, which would be on my back. The PTA or a caregiver or partner, just another individual, can grab the residual limb and slightly bring it into an extension, and you should feel the stretch here in your hamstrings. There we go. So slightly into extension. So that's just to avoid a knee flexion contracture. All right. And now another way to do it could be in a long sit position, or just having your legs in extension and then trunk flexion, and then you should be able to feel the stretch in your hamstrings.